Okay, well, thank you, Rupert. Congratulations on the conference. Great to see everyone in person. You look much better than you do on a laptop. So nice to be here, and good to see meetings back in person again. We're going to speak to the domain-based outcomes. Maybe I'll start off with the rationale for this. We have been focusing on MADRS improvement in adults with treatment-resistant depression. The relationship between MADRS improvement and functional outcomes and patient-reported outcomes is very weak, actually. And so we've been especially interested in trying to figure out how can we improve PROs, patient-reported outcomes, in people with treatment-resistant depression. And that's really been the guiding, overarching motif for this work. Disclosures, different organizations I work with in different space. Okay, so what I'm going to do is, in this time, I think I have about 35 minutes. I thought I had about 25 minutes. This is great. We're going to focus to some degree on reward systems. We're going to then pivot and talk about general cognitive systems. And we're going to talk about patient-reported outcomes. And I'm going to share with you different data points. It's real-world evidence from a data set that Josh Rosenblatt and I have created in Toronto. We have 4 centers in Canada that provide ketamine in the community, IV ketamine, and these data sets have been, and these data points have been obtained from those data sets in our program. I want to start off with this because we have Rob Berman here today. And when I think about 3 giants in mood disorders, we got John Cade in lithium, we got DeLay and Denneker with their work in chlorpromazine and mania, and we got Bob. So thanks for the work you did. It was amazing. So thank you for that. Now, looking at this, the point I just wanted to bring up is I've worked with industry for 25 years. And what has been the strategy in product development has been to reduce depressive symptomatology. And there's been a pivot shift in the last decade or so towards more PROs. And a different hat that I wear as director of the Scientific Advisory Board for the DBSA, which is an advocacy group in the United States. We've been in discussion with FDA about possibly changing the way we think about measuring outcomes with new therapeutics in depression, possibly having patient-reported outcomes as the primary outcome in clinical research. So some of you in this room invest in crypto, and some of you invest in electric vehicles. I would argue invest in placebo, if you look at this slide, okay? This is the last 5 decades, 4 decades, but that's not the point. I'm not here to give you investment advice. I think this is really a statement about we are stuck. Now, you could say that we're stuck. For those who maybe don't understand this area as fully, would say that there hasn't been any advances in pharmacology and depression for 5 decades. That's not the conclusion. That's the wrong conclusion. But what I would say is that this slide here is more the zinger. And this is, in fact, from the STAR-D. And you've all seen the STAR-D study. But for me, this is the most important outcome I took away from STAR-D. And this is a look at quality of life and functional outcomes as a function of sequential monoaminergic-based antidepressants. So we started to look at this very carefully. What we discovered was that there was really no relationship in many studies, and really a very, if anything, a small relationship between depressive symptom improvement as we measure it by a clinician's perspective in quality of life and functional improvement from the patient's perspective. And we've been talking about ketamine treatment in adults with depression. And our impression early, 5 years ago, we started to use this quite frequently, was that this was actually a very different treatment. This was having an effect on outcomes that we don't typically measure, very positive outcomes on metrics that we don't usually include. The other part, which we've said very little about today, is suicide. Of course, COVID has complicated this analysis in a very way no one could have ever had the prescience to know. But this is another part to the story. And it's a question that still remains open. Currently, in observational work, we have lithium as the anti-suicide drug, at least in observational work. And this is something that I'm going to come back to a bit later on. So let's, in fact, if we can, just start off with a bit of a glossary. We've made reference to anhedonia, some of the presenters today. We've made reference to reward-based function. You could disaggregate the phenomenology, the neurobiology of reward into its atoms, its various components. And these are not entirely separable, but they do, in fact, have separate aspects. And with our work with ketamine, we've been looking at all four of these areas. And it clearly is the case that ketamine is having effects. And we're seeing this in neurochemical work around looking at neurochemistries implicated in various aspects of reward, as well as various paradigms that we have to evaluate this, you can see here. So we typically talk about anticipatory and consummatory reward-based disturbances. That can be broken down a little bit further into decision and action-oriented type reward aspects that we are looking at in some of our paradigms. So just to put a fine point on this, this is actually looking at psychosocial outcomes in people with depression who are treated with monoamine-based antidepressants. And as I said a moment ago, we have very little relationship between MADRS improvement and PRO improvement with conventional antidepressants. And this area of reward has been one of the more enduring deficits in depression. And for those maybe a little less familiar, 75 to 80% of people will report anhedonia. Populations with TRD are more likely to report severe anhedonia disturbances. The other part related to this is that this is in fact often a persistent phenomenon in people with TRD and will portend relapse and functional impairment. And this has been highly shown in our literature. This is in fact just two snippets, because this is really the state of the union. We talk about comparing S-ketamine and ketamine to other benchmarks like SSRIs and so on. But I think, in fact, we should be a bit more fractionated how we think about this, maybe comparing them on dimensional or domain outcomes that matter most from a functional outcome or quality of life perspective. So this is data from GenDep and STAR-D looking along the x-axis. The greater the severity of at least one item, I would not say this does full justice to anhedonia, but at least one of the items of that taps into anhedonia is in fact a predictor of non-response to the SSRI, the SNRI treatment in these studies. There are in fact some data for some agents in the so-called biogenic category that they in fact can benefit aspects of anhedonia. And what's interesting is that this benefit, which has been observed in animal models with 40-octane, has been reversed with AMPA blockers. So there has been a suggestion that the benefit that we've seen with 40-octane, one of the few agents we have that are pro-cognitive in depression, as well as the benefits and reward, can be reversed with an anti-glutamate agent. And that caught our eye very early on. And there's been a number of work analysis now showing this mediational effect on functional outcome by improving anhedonia. It's been very difficult for us to demonstrate through mediational analysis the improvement on quality of life or function in persons taking biogenic amine antidepressants, because most biogenic amine antidepressants don't help anhedonia. And if anything, they can worsen it in many cases and often presents us with a blunting presentation. And again, just so we set the stage, this is the only drug the FDA has allowed the sponsor to market the product with claims that it can in fact benefit cognition in adults who have depression. The benefits in cognition are independent and are direct of the improvement in depression. So what we did was we did an analysis of this looking at a sample, and this was what really provided the basis for several grants with ketamine that we now are looking at in this space, is whether or not there's any relationship between improvement in cognition and performance on one of these reward paradigms, as being the effort paradigm, which is really a kind of an anticipatory type reward paradigm, but also taps into aspects of action. And the takeaway message is that we did find there was a very significant relationship between these two disparate but overlapping outcomes, that being improvement in cognition and improvement in reward. And neurochemically, this drug engages dopaminergic systems as well as glutamate systems. So we began to wonder whether or not some of the improvement in quality of life and function that we were gathering at point of care in people who have ketamine treatment was in fact somehow related to improvement in some of these dimensions and domains, that being cognition, that being reward. So Carlos is here, we got Jerry here, Josh is here, we've got 24 other colleagues around the world. We created really what I thought was really needed in the field, that being a set of parameters, guardrails for implementing ketamine and S-ketamine in clinical practice. This was published within the last year. But in this sort of State of the Union summary and synthesis of the field, one of the calls to action was in fact to study ketamine, S-ketamine, derivatives of ketamine, isomers, and so on, less so with respect to an eye on total MADRS improvement, but maybe more so with a view to targeting some of these dimension domain outcomes, because they seem to be at least more proximate to some of these quality of life in PRO measures. So we've said a lot about drug development here today, and we talk about identifying patient populations. What I learned a long time ago was that the part of development that doesn't receive as much attention is to make sure you actually have the right measure, that you have the right measure for the treatment that you're actually giving. So the MADRS scale was developed largely on improving biogenic amine-treated patients. We didn't have a scale that we were aware of that was developed or had a sensitivity to change in persons, in fact, that were treated with, in this case, we'll call it a glutamatergic treatment or a rapid-acting treatment. So Josh and I, in fact, thought we would look at this. And what was really interesting is that we decided we were going to go back to the QIDS-SR in our database, and we've had now over 5,000 treatments at our centers. And what was interesting is that we decided we were going to have a cut score of a 30% improvement on any of the items on the QIDS-SR as being MCID, as minimally clinically important with respect to difference. And what was interesting to us is that this was very much in accordance with what we were observing clinically, that some of the most responsive items on the QIDS-SR were items that were tapping into positive valence disturbances, positive affect, the capacity for positive affect, the aspects around motivation, aspects about experiential pleasure were captured in this scale. So again, the MADRS scale was derived from a larger battery of items. And what was done was the larger battery was looked at. Persons were treated with tricyclics and various monoamine-based antidepressants. The most responsive items created the MADRS. So the MADRS was built on what are the most responsive items to monoamines. And this is, in fact, the scale that Josh and I built that was most responsive to ketamine. So these items showed the most change across time in our data set. Now, why would we be thinking about ketamine and anhedonia? We heard an excellent presentation earlier around the alcohol. This was a study from Exeter, an excellent study. That certainly is one indirect piece of evidence around possible effects on reward and or general cognitive systems. Going back 25 years ago, I started doing research with inflammation and depression. And the way this story is told is that there's about a third of people with depression exhibit what's called a pro-inflammatory balance. We've moved along a little bit from that very sort of simple statement to perhaps a more granular characterization of this with respect to the fact that there are select domains or symptoms of depression that are most associated with pro-inflammatory changes. And those domains are largely in sleep, in cognition, and reward. This was an item analysis that tried to really suss this out very carefully, and this has been replicated many, many times. So when we think about reward systems, we think typically about dopamine, we think a lot about opioidergic systems, but we also contemporaneously are thinking about inflammation. And ketamine has a number of effects on inflammatory systems. It stabilizes microglia from the so-called M1 phenotype. We also know that it reduces the release of a variety of pro-inflammatory cytokines, E.G.IL-1, IL-6, TNF-alpha. And the other part about this, which is worth mentioning, is that in people who have depression, who have pro-inflammatory balance, they exhibit an elevated kynurenine level, in fact, what's called an elevated kynurenine tryptophan ratio. And that ratio in the periphery is in fact then correlated with an increase in glutamate concentration in the basal ganglion. In other words, what you begin to see is excitotoxicity in the CNS in select brain regions driven by some of the metabolites of the kynurenine system, one of the most characterized being the quinolinic acid moiety. So it stands to reason then that it's possible that some of the benefits that we're seeing in this area, in fact, could be through any one or more of these systems. So I'm not going to go through all the rationale here. We have neurochemical rationale to consider ketamine in this area. We have animal models. We have a variety of behavioral paradigms. And we've also, not leaving out the anti-inflammatory part, this is just looking at the so-called monetary incentive delay task, which is an anticipatory as well as a confirmatory task in the MRI machine. And what's been shown over and over and over again in this space is that as you begin to exhibit elevation in inflammatory markers, it's the intermediate reward systems that are rewards that are most susceptible to an increase in inflammation. And so we go back to patient populations. I said about a third of people with TRD, or sorry, a third of people with depression have elevated inflammatory markers. And it turns out that in populations that are TRD defined according to 2 or more failures, it's closer to 40 to 45%. So they're more likely to have a pro-inflammatory balance. And for now, what we really have is more correlative studies. We just have correlative association studies. People have been looking at this. Is there, in fact, a change in some of these markers with ketamine treatment across time? And I think for now, we're just going to say it's largely in the area of hypothesis. It's observational. We don't know. And we certainly don't know whether stratifying patients on the basis of an elevated marker in fact, necessarily would identify a group more or less likely to benefit from this treatment. But the takeaway is that we do think that this effect, as well as some of the other well-known effects, are rationale. One final point around this is some of the connectivity data, resting state, functional connectivity data, whether one's looking at striatal structures, habenula, we can keep going, the anterior cingulate cortex subgenual. So these substrates that are participating in anticipatory reward, or we can go to other structures like globus pallidus, nucleus accumbens, and so on, structures observing consummatory reward systems have been implicated as abnormal on their own as nodes, but also some of the functional connectivity effects have in fact been observed to be abnormal in people with treatment and corrected, in fact, with ketamine treatment. So we just recently summarized this area more with kind of with a view to try and set sort of vistas for future research. I wanted to share with you some data. So this was a study that Josh and I, one of our colleagues, Nelson Rodriguez, published from our center. These are real-world patients. These are people who have failed 6, 7, 8, 9 different treatments. They receive 4 to 6, mostly 6 treatments IV ketamine. We looked at an anhedonia measure. So again, we have 4 different subdomains of reward. All 4 are affected in depression. Some would argue that the anticipatory aspects are more impaired in depression than are the consummatory aspects. Notwithstanding, the consummatory are easy to measure, and we have a variety of measures. There's the Fawcett-Clark, there's the Chapman, the Snaith, a few others. We use the Snaith measure in our program, and over time, what we found was that there was an improvement in measures of anhedonia. And I should also mention that in this group, most people had severe anhedonia across time. What was also interesting in this analysis when we ran it was that we looked at mediational effects of changes on SHAP score on overall depression improvement, overall effect on suicidal ideation, a point that came up earlier, and also the effect on anxiety. And we do know that there is, in fact, a large literature actually linking cognitive impulsivity as well as anhedonia to suicidality. And we are especially interested in trying to sort of decompose this a little bit and look at some of these mediating factors. And we found up to 20% of the improvement on depression and SI was in fact directly an improvement, a direct consequence of the improvement on this anhedonia measure. So we're talking about improving a dimension domain, but this is in fact, in our view, relevant to obviously a critical other endpoint being SI and also function. And again, this has been looked at by other groups, some colleagues of mine in China doing this as well. So we're going to, I think, look at this more. There's a couple of studies we're just starting up in bipolar depression, which Josh may speak more to on Wednesday. But also integrating internet-based CBT with ketamine. These are 2 studies sponsored by the federal government that we're going to, in fact, be looking at some of these questions. I'm just really touching on very briefly here today. I want to just say a couple of words about cognition. I took an interest in this quite some time ago after 5, 10, 15, 20,000 patients, one after the other through my office, who I treated to remission with, and I was smile like a Cheshire cat when they were in remission, only to find out the patient wasn't functioning any better. And we went backwards on this, and we found out again that deficits in reward and deficits in cognition were the principal reasons they weren't functioning. And this was often linked to adversity, but it was really what's most important to this conversation today is it wasn't related to the severity of depression in most cases. It was actually related to their, the duration of illness, the multi-episode illness that these folks were having. And when we did an analysis of this, we found something really interesting. This was an analysis, a partnership I had with a good friend of mine, David Muzina at Cleveland Clinic in Ohio. We looked at all comers coming to the clinic with depression. So we heard an interesting cost analysis earlier. And one of the aspects about cost analysis is presenteeism. And most of the cost in depression is due to presenteeism, not absenteeism. And so we measured both in our cohorts at Cleveland Clinic in Toronto. And what was really interesting to me was that there was almost no relationship between workplace attendance and performance and the overall severity of their depression. Almost no relationship. That accounted for less than 20% of the variance. It was actually driven mostly by reward measures and cognitive measures. And this was something we weren't as familiar with when we ran this analysis, but it really hit home this point and perhaps was capturing something we hadn't been measuring that could help us understand why so many of these people, despite being put into remission on a QIDS or a BEC or a MADRS, weren't in fact going back to work. So for those maybe who may be a little less familiar with this, this has not been sufficiently studied. And I guess at first we should maybe, we're all aware that amongst recreational use of ketamine, it's well documented there's an anti-cognitive effect, and that's certainly well described. We also know that for those who recreationally use this or in animal models, there is a toxicity, there is a neurotoxicity. And I remember the days of MK801 when it was being developed, it was actually shelved because of the neurotoxicity. Things like Olney lesions, the hyperphosphorylation of tau, as well as the loss of parvalbumin containing GABA interneurons. All this has been described with high doses of ketamine. Again, doses far exceeding what we would use. So we're aware of that going into this. And if I was to summarize this literature, this is actually one of our graduate students for Josh and I, who actually published this recently. It's an open question. We do have some benefits on some measures of processing speed. We've seen some measures of verbal working memory in some studies. Other colleagues have been looking at whether it's a baseline predictor of response, and I think right now we just don't know. But this is actually some data we published a few months back. Again, this is real world data. We collected a variety of measures. We had just on this slide, I just happen to have this slide with me, so I included it. We've got trails in the PDQ-5. PDQ-5 is subjective. Trails is obviously set shifting and executive function with a bit of processing speed. And what we found was in these patients, it was about, I think about 250 patients or so. In this particular cut of the data, there was improvements on these objective measures and on these subjective measures. But again, this is not randomized, it's not double-blinded. You don't have control for practice effect here. We did, to the extent we could, try to separate this benefit from the improvement in depressive symptoms, which we did. I think I have the slide. I don't there. Okay, I was going to show it to you. But anyways, come back here. But this has in fact been now seen in a couple of groups have been looking at this. Sorry for how tightly wound this is, but this is also documenting across time improvement in cognition. So for now, what we have a rationale to look at this as a primary outcome in a clinical trial. So for those maybe again on trial design, to make this sort of convincing, we need to have cognition as the primary outcome measure. We need to have a double-blind RCT with a placebo because of practice effect. And we need to have upfront a way to adjust for the effect of the improvement on depression, not only for self-reported cognition, but also objective cognition. And that's in fact what we're about to do. These are some work from a colleague of mine, Yanling Zhao in Guangzhou. And again, goes back to that mediational analysis I talked about earlier, that being the improvement on a reward measure having some direct independent effect on a quality of life and functional outcome. And this was looking at, in a Chinese sample in Guangzhou, looking at repeat dose IV receiving ketamine, 6 treatments across time. But the primary question was, what was the effect of this treatment on cognition measures, and what was that, and was there any kind of direct or indirect effect on functional outcomes? And what was found in Yan Ling's work was that this accounted for about 25% of the improvement on the total objective, but there was also subjective measures, this being the Sheehan. So a substantial amount of the variance was explained by that. One idea that we've been marinating for quite some time internally with the group is whether or not the anti-suicide effect in ketamine with ketamine could in part be a manifestation of procognition. And this is something that we don't have the answer to. We're thinking this through. It's in one of our studies we're about to start. It was, the phrase is often stated, things often happen suddenly and then gradually, then suddenly. And this is in fact certainly the case with ketamine. And we had just finished a protocol in Taiwan where we had discovered that methylphenidate was highly significant at reducing suicide in Taiwan. In that program, we were testing the hypothesis that a treatment that can reduce impulsivity could have potential for being, in fact, anti-suicide at the patient level, the population level, and this, along with benefits in cognition, in reward, is something that we're looking at now in our current study. One final comment is around function. So when we think about adults who have depression, we often state that once you've failed 2 antidepressants sequentially, the chances of the third one taking you to clinician-rated remission is around 10 to 14%. The chances of your quality of life improving is around 4%, pretty low. Now, one other aspect that we should think about is baseline function. And one of the most replicated observations with conventional antidepressants is the persons with lower level of baseline function are less likely to benefit acutely from conventional antidepressants. Said differently, people who function higher are more likely to benefit. And this was something that is interesting because it probably involves aspects of cognition, behavioral activation, reward, and motivation. So we ran this analysis, Josh, I, and the team, with our own data set, and we found something very different. We found something very different than the conventional antidepressants. So we know that about 2/3 of people who have depression, especially with TRD, are severely functionally impaired. And severity of functioning at baseline is an adverse prognosticator on the next SSRI. But what Josh and I and the team found was something quite different. I have the slide with me here. Oops, Daisy. I have the slide with me here today. And what we found is that baseline functioning did not moderate in any way response to ketamine treatment in our sample. This was close to 300. So that's quite different than all the antidepressants. Secondly, what we found was that the magnitude of improvement in functioning was greatest in people with lower levels of functioning. And then what was also really interesting was that that's the group that also exhibited the greatest antidepressant response after we adjusted for baseline severity of depression. So we had interpreted that as possibly being evidence of maybe behavioral activation, aspects of motivation and reward that are being facilitated in these persons, and then they're getting more back, they're able to sort of engage families, engage interpersonal and vocational function. So going forward, this is something we're looking at from different perspectives. So finally, just maybe to wrap up. So I think that really for us, what we're trying to do, we're not actually trying to convince ourselves that we can improve a clinician outcome measure. I don't think that's needing to be done anymore with ketamine. Moreover, improving a MADRS score does not have really much to do with patient outcomes anyways, for most of these individuals. So I don't think it's actually experience near. The emphasis that we're in fact taking is trying to in fact identify what are the principal mediators or PROs. And let's see if we can actually target those systems with ketamine so that we can actually translate that into a better functional outcome. And for now, this real world data has given us reasons to believe that this is quite possibly the case. So I'll stop there. Thank you.
Talk with time for questions. Sure.
From Flexio. I would like to ask you which PRO would you recommend to assess functioning, especially after ketamine treatment?
Yeah, it's a great question. We have been discussing this now for quite some time. There's no short answer to that. And so far, we have over 50 PROs that have been considered. And this has been a discussion we're having with FDA as well. And we don't yet have a consensus on that. What we've been using is Sheehan, but I don't think that necessarily is the only one. But I think what if someone here wants to do it, what the field can benefit is an answer to your question, because I just be giving you my opinion. We just use Sheehan for now. With respect to the actual PRO, are you looking at more a functional outcome? In that case, you probably want more of a performance-based functional outcome, or you're looking at more of a quality of life outcome, which tend to be very multidimensional outcomes. For now, we don't have one right now that I could say is a gold standard. And that was the question that the FDA has also been posing to the DBSA. So don't have it.
Quiet.
Thank you so much. We also thought about instead of having remission with MAGAS to assess the function, but we thought that was kind of internationally impossible because that would be affected of the possibilities for sick leave and the insurance policies within each country. So how do you think the possibilities not to work and survive at the same time can affect the patient's functioning level?
I'm not sure I got that. So,
I mean, the patient's functioning level, I mean, their ability to work or not to go to work
yes.
is somewhat affected by how much the society.
Oh, I
takes
see.
care of
Yeah,
it.
yeah. So that's a good point. So clearly, if someone's been off work, if work is defined as working outside the home for 5 years, it's unlikely that 2 weeks of ketamine, they're going to get their office desk back in the next day. So that point's well taken. But you can look at presenteeism in different ways, and you have different ways in which work has been defined. So yes, in a more sort of narrow sense, work means an employment outside the home in a 9 to 5 job. That point's well taken. But we kept it broad, and certainly on the cost effectiveness analysis, this has to enter into that equation because that's where most of the cost is coming from. And certainly the challenge, especially with managing depression in the workplace, broadly defined, that's where most of the cost is coming from to society. So clearly that's where we have, you want to obviously study depression in the habitat that it exists. So you have to be there. But that point's well taken. So we look at this absenteeism presently, but we broadly define it. It could include homemaker status. It could include volunteer status, student status. You can make it broader. And that's what we've been doing.
Last question. Did you look at any interaction between age and the patient-related outcomes and workability, premorbid functioning?
No, we haven't. Not in the way that you're describing it. We haven't. But I'm still thinking about the data we saw with the ketamine response for those under 50, and that question came up. You asked the question as well, and I think this is really an interesting point around that. And when you asked the question, I thought it's a great question. And I started to wonder whether or not that we talk about plasticity and whether circuit signatures are as malleable early in trajectory versus later in trajectory. And then I started thinking about the recoverability of cognitive functions, the recoverability of reward functions in people less than 50 versus over 50. I started wondering about when you asked that question. So I don't think we know. We've looked at that.
Questions back?
Yeah. So you've emphasized the importance of cognition on successful functioning. There's a large literature on adding stimulants to antidepressants. They didn't really improve the depression, but in the real world, they actually do help people get back to work quite effectively. So I'm wondering what you think about that, and particularly, do you think that ketamine may be pro-cognitive, but do you anticipate ketamine plus a stimulant as being the ultimate cocktail?
That's a really interesting question. I'm sure patients would like that. I think it's a great question, Sigar. And you're right. So when we look at psychostimulants, and this is a really, really interesting point from the drug discovery and development perspective. We've looked at this, we've published on this extensively, that when you add a psychostimulant to a conventional antidepressant, and you look at depression outcomes, that is the total MADRS score versus placebo, you get a rather underwhelming result. But when you narrow your scrutiny to the cognition measures, to your point, you get a very significant improvement, actually. And just like you're going to develop treatments for cholesterol, we all want your total cholesterol back to normal, but I think we'd be happy with your LDL getting back to normal. And this is a larger question where obviously regulators have to be at the table and so on and so on. But certainly it is the case that psychostimulants have potent pro-cognitive effects, not just in people with identified illness, but in healthy controls. And it's an interesting question. So what we're doing instead is, although the pro-cognition data for cognitive behavioral therapy are not as robust as its namesake might suggest, at least on cold cognitive functions, we are starting a study supported by the Canadian federal government where we are taking all people with TRD that come into this study, and they're all going to be getting CBT, manualized based through the internet, and then they're going to be getting IV ketamine or a control. And among other things, we're going to be looking at that very question around cognition and impulse control. So using cognition as the psychostimulant, but I think your points, Edgar, is well taken. And it was interesting that in our Taiwanese study, it was the stimulant that reduced suicide, actually at the level that was comparable to the signal we saw with lithium in the same country. So it was very interesting.
Another question over here.
Yes, so there is more and more evidence about the effect of ketamine on anhedonia in MDD patients, but I was wondering if you think that it could also help on anhedonia in other indications, not MDD.
Well, that's a great point. I never get into this. I'm just sort of giving more breadth and depth here, but you're right, because cognition and anhedonia are transdiagnostic. And I'm speaking about depression here today, but we see it across many different disorders, not just in quote psychiatric disorders, but you see it in medical disorders, which is kind of a silly way of dividing it out. But absolutely, and you can think about people who have bipolar illness, you can think about other diagnostic considerations. So the answer is yes. But what's abundantly clear in this field of TRD is that MADRS outcomes do not correlate very much with functional outcomes or patient-reported outcomes. And so we need to have that there because that's the gold standard, as we've been using and so on. But I think we're going to need to think about this very differently. And I think that the reward outcomes and the cognition outcomes are probably closer to the patient experience. But yeah, I think this is one of the advantages of this, that you can maybe have some transdiagnostic application of it. Okay, thank you.
Thank you very much.
you.